Hello and welcome to part 2 of chapter 6, Autosomal Inheritance and Disorders. Okay, where we left off in this last section, we talked about the non-disjunction being the main cause of trisomies, but we also ended up talking at the end about balanced translocation carriers also having a conception that results in a trisomy as well. But most commonly, trisomies occur from non-disjunctions during gametogenesis, and any chromosome can result in non-disjunction, but trisomy 21 is the most common that results in a live birth. Trisomy of most other chromosomes are incompatible with life. So the top 3 common trisomies are for living births are trisomies 21, 18, and 13. These can result in a term pregnancy because they contain relatively few gene alleles. Trisomies of chromosomes with large number of alleles are more likely to be lethal to the embryo. So again, as mentioned in part 1, most commonly trisomies are from non-disjunction during the meiosis of the ova, but can occur during spermatogenesis also. Okay, so we're going to continue with trisomy 21. Okay, it's Down syndrome is trisomy 21. It results in Down syndrome. It's the most common trisomy among live-born infants, as I've mentioned. It affects males and females in all races equally. The incidence is 1 in 800 births. It is associated with advanced maternal age. The phenotypic expression has many features, but not every person has all of them. There's some variation with that trisomy. Individuals do share variations in skin, hair, and eye color with family members, but there are some very specific facial features that are common to all children with Down syndrome. And some of those associated features are they have a palmar or simian crease across the palms, epicanthal folds, flat faces, widely spaced eyes, slightly low-set ears. There is a variable amount of the decreased intellectual development. The potential for that is really not predictable because it really depends on the environment and what kind of resources they have to help these children be as optimal and functional as they can be. They are commonly have congenital heart defects, especially a cardiac cushion defect. Now, the cardiac cushion defects, what that refers to is when the walls separating all 4 chambers of the heart, they're poorly formed or absent. Okay, so you've got a mixing of oxygenated and deoxygenated blood, and a lot of them may need actually some cardiac surgery shortly after birth. Okay. They tend to have a small, short nose, brush-filled spots, which is a speckling around the iris, okay, in a circle around the iris. I've got a picture of that coming up. They tend to have a short neck with limited motion and extra skin folds. Short little finger that curves inward. You can kind of see on this one hand of this child that example of that curving inward in the short fingers. Have a wide gap between the first and second toes. Intestinal obstructions at birth. They tend to be shorter in stature than their siblings, with thicker lips and a slightly protruding tongue. They have poor muscle tone and reflexes at birth. They are more likely to have vision and hearing losses at earlier ages, along with cataract formation. There's a high rate of hypothyroidism among trisomy 21s. Premature aging, and they have an increased risk for leukemia. So here's a picture of those brush-filled spots, that salt and pepper speckling of the iris that's often seen in Down syndrome, okay, all the way around the eye there. So here is a trisomy 21 karyotype. You can see that you've got the 3 21s on that bottom row, and so that's the karyotype for Down syndrome, and the little girl to the left is the phenotype. She's pretty cute. Okay, so moving on to trisomy 18, which is otherwise known as Edwards syndrome. That affects females more often than males. All races are equally affected, but it affects females more so than males. The incidence is 1 in 3,000 to 1 in 5,000 births, so not as common as Downs, but it is the second most common trisomy. Most are stillborn. Live-born infants usually die within the first year. There's many features associated with trisomy 18, and not every person has all of them. I'll show you some pictures coming up of those features. Individuals share variations in skin, hair, and eye color with family members. They tend to have, they do have decreased intellectual development to severely compromised intellectual development. So again, there's sort of a range there. They have small strawberry-shaped head with receding chin and elongated occiput. Clenched fists with overlapping fingers. They also have a single palmar crease and low-set abnormal ears and rocker bottom feet with a prominent heel. So here's a picture of that rocker bottom foot, and then again another picture of an infant, of a baby with Edwards syndrome, with that strawberry-shaped head. I know that sounds kind of odd, but that's how it is identified in the literature, as the strawberry-shaped head, which is very characteristic of Edwards syndrome or trisomy 18. They do have kidney malformations, heart malformations, esophageal atresia. They may or may not have an omphalocele, okay, which is also called exomphalos, EXOMPHALOS. That's where the abdominal organs remain outside of the body in a sac. Usually it's mainly the intestines and the liver, but can include other abdominal organs. And these fail to return into the abdominal cavity during week 9 of intrauterine development. They also have inguinal and umbilical hernias and brain cyst. Okay, trisomy 13, also known as Patel syndrome. Okay, so that occurs in 1 in every 10,000 newborns. Most cases they're not inherited. It's just an event that leads to trisomy 13 to occur in either the sperm or the egg that forms the fetus. So again, during gametogenesis. The syndrome involves multiple abnormalities, many of which are not compatible with life. So more than 80% of children with trisomy 13 die in the first month if they are not stillborn. It affects females more often than males. All races are equally affected, and I've mentioned the incidence already, 1 in 10,000 to 1 in 16,000 per your textbook. I've mentioned most are stillborn and that live-born infants usually do not live very long. Okay, they usually die within the first year. They also have decreased intellectual development to being severely compromised. They have a small head, small lower jaw, that micrognathia, cleft lip with or without cleft palate, a clenched fist with overlapping fingers. You can you see that here in this picture. And they also have extra digits on their hands or feet, polydactyly. And if you count this baby's fingers, there are 1, 2, 3, 4, there are 6. So that is a polydactyl hand. They also have low-set ears. They, just like the trisomy 18, they have the rocker bottom feet. They have fusion of digits on hands or feet. They have an abnormal iris, okay, split off-center, keyhole-shaped. They can have a fusion of brain hemispheres and inguinal and umbilical hernias. Small close-set eyes, and they could be fused because remember those hemispheres kind of fused together. So you see that fusion in this right-hand side picture. They have many heart malformations, abnormal rotation of internal organs, deafness and visual problems, seizures, and apnea. And again, a cleft lip, palate, and often even a cleft face. Okay, now we'll move into partial chromosome duplications and deletions. Deletions are more common than duplications, and deletions result in loss of alleles. So that makes sense. You delete something, you take it away. So when we have a loss of alleles, we have a loss in genetic material. Duplications can result in triple doses of alleles. Larger deletions or duplications more likely to result in those observable phenotypes. Just like I mentioned earlier in the first section, that you have smaller deletions or a smaller component that's affected. There's less alleles, so the phenotype is less likely to be as expressed than in the larger chromosomes. Random events from chromosome breakage and rearrangement during gametogenesis is the cause of this. Some examples of identified partial deletions would be Wager syndrome, or Wagger syndrome, I've heard it pronounced, or WAGR. That is a deletion of chromosome 11. Retinoblastoma is an inherited deletion of chromosome 13. Cru-du-Chat is a deletion of chromosome 5. Then Angelman syndrome, deletion of chromosome 15. And Prader-Willi syndrome, also a deletion of chromosome 15. Okay, so a deletion, you've got a chromosome, you've got a break in the chromosome, that deleted genetic material gets lost, then the chromosome fuses together. You can see it's shorter and it has less of the genetic material than it started out with. Okay, or less than it should have. Okay, so Wager syndrome. So that stands for Wilms tumor, because this is what these affected individuals have. A Wilms tumor, which is a common pediatric kidney cancer. They also have, the A is aniridia, so they have loss of the iris, or a very small amount of iris. And so these are actually often identified at birth from the examination of the eye and seeing that loss of that iris. Okay, and so it makes sense that they would be very photosensitive as well. The G is for genitourinary involvement, so that could be hypospadias, it could be undescended testes in females, it's streak ovaries. These individuals are infertile, and also it can result in ambiguous genitalia as part of that genitourinary potential component. And the R stands for retardation. Of course, now that's referred to as just intellectual deficiency, but that is the acronym WAGR, that's what it stands for. Okay, and also I just want to mention these deletions, most are random events from gametogenesis, the formation of the sex cells. There is no relation here to parental age. Okay, and many of these are not capable of reproducing, so there's no chance of passing on these disorders. Cru-du-Chat syndrome, that means that's French for cry of the cat. That is caused by a deletion of the end of the short arm of chromosome 5. Okay, it affects 1 in 20,000 to 50,000, discovered in 1963, so not too terribly long ago. And then they have wide-set eyes, also a range of mental deficiencies, small round face, small jaw, feeding difficulties, low muscle tone, so they will need assistance with developmental delays and some strengthening to help keep them optimal. Low set ears and partial webbing or fusing of the fingers and toes. But that cat-like cry is very distinctive, and that's what gave it its name, Cru-du-Chat. Cru-du-Chat. Okay, Angelman syndrome. Okay, that is a deletion of maternal chromosome 15 from the section of the long arm from 11 to 13. The Q, remember, refers to the long arm of the chromosome. Okay, and here, if there is a deletion of the maternal chromosome, then only the paternal expression of alleles in this chromosome region exist. Okay, so no maternal expression, only paternal expression, you result in Angelman syndrome. It affects males and females in all races equally. The incidence is 1 in 10,000 to 1 in 15,000 births. Okay, even though it seems rare, it's out there. I remember we had when I was working in the school system, we had a child with Angelman syndrome in a pretty small town. So it's just it exists, and so it's important to to know even these rarities and how to help these children be as optimal as they can. Because they do have normal features at birth. The phenotype is more obvious as the infant ages. Okay, so their developmental delay is more noticeable by about 6 to 12 months of age. Seizures often begin between 2 and 3 years old. They tend to, not always, but they tend to get better as the child ages. They do have a pronounced speech impairment with little to no use of words. So again, their use of words is variable, but very, very, very limited, if at all. Okay, they have progressively reduced cognition. They are unsteady, a clumsy gait with some jerky motions, tend to do a lot of hand waving and hand flapping. Very characteristic of them to have inappropriate smiling and laughing for anything. It used to be referred to as the happy puppet syndrome. And so they always seem to be happy. They're always smiling. Okay, they have an excitable personality. I've mentioned the poor speech development, and their hair, skin, and eye color are lighter than that of their siblings. So here is a picture of the karyotype of Angelman syndrome, and then to the left is a male affected with Angelman's that came from your textbook, and then down here is a female. You can kind of see some of the features that we talked about. It's hard not seeing a video of some of their actions, but definitely a lot of smiling, a lot of laughing, just appearingly very, very happy children, but with some significant delays. So moving on to Prader-Willi syndrome, okay, so that is a deletion of the paternal chromosome 15 from the section on the long arm from Q11 to Q13. So when you have deletion of the paternal, then only the maternal expression it occurs in this chromosome. So that results in the Prader-Willi. So it affects males and females in all races equally. Its incidence is 1 in 10,000 to 30,000 births. Normal features at birth. The problems in infancy are hypotonia, so they'll have some developmental delay, poor sucking reflex, so failure to thrive in these infants, which is ironic because this syndrome is characterized by severe overeating, but that doesn't really come about until about age 3 where they get this insatiable appetite. So they have mild to moderately reduced cognition. They tend to be shorter than their siblings with small hands and feet. I've mentioned their appetite, excessive weight gain and obesity, poorly developed gonads and genitalia. Okay, as a matter of fact, their puberty is delayed if they go through puberty, but they also are typically infertile, and without hormones, the secondary characteristics will not develop. Their hair, skin, and eye color are also lighter than that of siblings, just like with the Angelmans. They have behavioral problems, poor impulse control, mostly in relation to food. But when obesity is controlled, obesity is their main health concern, physical health concern, all the complications with obesity. But when obesity is controlled, life expectancies are the same as with the general population. So here is a boy with Prader-Willi syndrome, and this can be a very, very hard condition to manage. I saw a documentary on this, and the family had to put padlocks on the refrigerator, on all the cupboards, and what they found was that he was on the way home. They thought he was all taken care of, and on the way home from school, he walked home from school. They found out, because he still kept gaining weight, that he was eating in garbage cans, going on side streets, finding garbage cans on the way home, and eating from garbage cans. So it is a very, very significant problem. Very hard on families, like the others. Okay, so now we will move on to genomic imprinting. Okay, it is a rare occurrence in which the genomic input of one parent's allele or alleles fails to contribute to the offspring's phenotype. So a gene tends to be inactivated. So the DNA sequence is normal, but the expression is inhibited. So usually both copies of genes, one from mom, one from dad, are active or turned on in the cells. But in some cases, only one is active. So that's what this is talking about here. Only a small percentage of all human genes undergo genomic imprinting. Occur most commonly on chromosome 11 and 15. Okay, so it also occurs occasionally through the process of uniparental disomy. Now what that means is you've got two copies of a chromosome that come from the same parent. Instead of one from the mom, one from the dad, both copies come from the same parent instead of one coming from each parent. So Angelman's and Prader-Willi syndrome can also occur by this process of uniparental disomy, okay, or the genomic imprinting. Okay, so with both chromosome 15s coming from just one parent, coupled with what we know about different syndromes resulting from a deletion in chromosome 15, that indicates that for some genes there is a difference between a normal gene allele contributed by the father compared with the same normal gene allele contributed by the mother. So uniparental disomy may happen with some parental chromosomes that are not qualitatively different, and then no disorder results. Okay. Okay, so another way of altering the input of one parent's allele contribution involves the epigenetic influence silencing one parent's normal but recessive allele. Okay, so which is what we talked about just a little while ago. So if one parent's alleles for the same recessive trait is mutated, the mutation is expressed because there is no expression of the normal recessive allele from the other parent. So genomic imprinting issues are not terribly clear at this time, so definitive statements and risk and probability are less accurate. Okay, so there's kind of a wide range of results here. But generally speaking, you've got uniparental disomy, you got two copies of chromosome coming from the same parent instead of one from each. You've got a gene that can be inactivated, so the sequence is normal, but the expression is inhibited, and so those are the two main concepts with that there. So mosaicism, okay, autosomal mosaicism, sorry, this can be hard to say, is a condition in which two or more different karyotypes are consistently present in one individual from different cells. Okay, so for example, mosaicism is not as the phenotype expression is variable. For example, a person with trisomy 21 may have some blood and skin cells with a 47 XY plus 21, 47 because remember they have a trisomy, so they have one extra chromosome there. So they have a 47 XY 21 karyotype and some blood cells and skin cells with a normal karyotype, a 46 XY. Okay, so we're talking about a male here, karyotype. So again, the degree of phenotypic expression of either karyotype depends on the percentage of cells within a given tissue that have a normal versus an abnormal karyotype. Okay, there's a picture and we can see what that looks like coming up. So there have been individuals who have a persistent expression of both normal karyotypes and trisomy 21 karyotype in blood and skin and have classic trisomy 21 features but have normal to high intellectual functioning. So we see this variability with Downs because remember there's also we have to consider mosaicism because not all cells have that trisomy. So they might not have that much, they might be highly functional and don't have that great of a delay, cognitive decline or cognitive deficit. So the explanation of unaffected intellectual function in a person identified as having trisomy 21 is mosaicism in brain neurons with a high percentage of normal neurons compared with trisomy 21 neurons in the brain. So that accounts for that difference. When I was in the schools, there was a student with mosaic Downs, and she was not in the special ed room. She took the test like everybody else. She did not have any significant effect on her intellectual ability to function in a normal classroom. It varies by tissue and has its start in early embryonic life. Mosaicism represents an error in chromosome segregation after conception, which means that only some cells have the error and others do not. So the normal and abnormal cells are not evenly distributed in all tissues. Okay, and here's that picture I was talking about that was coming up. So here you've got a zygote with 46 chromosomes. You've got an early embryonic with all cells, okay, with looks like they're all normal, and then you've got, so down the line you've got an error in cell division occurring, resulting in the formation of a 47 chromosome cell that continues to divide, okay, and so you've got so then it continues to divide, and so then with further division, you can see how you can have one twin. Let's say this is an example with a monozygotic twin. So when that twin, or when that cell divides and forms two individuals, then you can see how one individual is more affected with the Downs traits, the trisomy 21s, and then twin B. Okay, there's with very few expression. So there is a variable expression with a mosaic Downs child. Okay, and that wraps up our highlights of Chapter 6. I hope you enjoyed that. It's really interesting. This is going to get even more interesting as we go along and we talk about the genetic components of disease, okay, and as well as possible environmental influences as well. So if you have any questions, again, please feel free to contact me in my email or my phone. I appreciate it, and have a good day. Thank you.